now we are going
Thank you.
to the south. We are going to Libya. We are going to Tripoli. And now Marwa Ali Ahmed Doufani will present results from Libya on psychosocial risk, eating habits, and cardiovascular disease. So you're very welcome, Marwa, to present now.
Hello, everyone. Can you see my screen?
Yes.
Okay. And is it presented right now?
Yes.
Awesome. So good morning and good evening, everyone. My name is Marwa, and I'm a master's student at Yeditepe University. I'm excited to share with you the primary results of my thesis study, which is on the association between psychosocial risks and eating habits and eating quality and physical activity under the supervision of Dr. Eugène Demiral. All right, so psychosocial risks have been approved to have adverse effect on the physical health as well as the mental health. So for example, job strain and long working hours are linked to higher risks of cardiovascular diseases. So there are 4 proposed pathways that link psychosocial risks to cardiovascular diseases. The first pathway is the neurobiological pathway. Psychosocial stress can activate the amygdala, which is a neural center important in stress response. This results in the heightened activity in the hematopoietic tissue and subsequent arterial inflammation, which are related to or linked to cardiovascular events. The second pathway is the oxidative stress pathway, where psychosocial stress disturb the redox hemostasis, which induce oxidative stress and lead to inflammation and endothelial dysfunction. The third pathway, where stress affects the hypothalamic pituitary adrenal axis, which increase some stress hormones such as cortisol. And this results in the increased blood pressure, increased blood glucose level, and it also affects the lipid metabolism, which are all significant risk factors for cardiovascular diseases. And the last pathway, which is the pathway we are interested at in the study, is the behavioral pathway. Stress can lead to some health behaviors such as smoking, physical inactivity, unhealthy eating habits, which are all well-documented risk factor for cardiovascular diseases. And under high stress, these behaviors usually are worsened because individuals adapt them as a coping mechanism. So why this study is important? Even though that these risks or these psychosocial risks affect the health, the research on this area remains scarce, especially in the African countries, particularly in Libya. So this is alarming because given the fact that less than 30% of the developing countries have explicit rules or regulations on psychosocial risks, which is far less compared to the European countries, where there's 82% regulations in the European countries. So this significant disparities between in the regulations lead to uneven workers' protection or protection of workers, and this can affect the global health adversely or negatively. So our research does not only fulfill the gap, the crucial gap in the literature, but it also urged the need or or highlights the need for research and interventions in this kind of or in this area specifically. So as mentioned, the country of the study is Libya. For those who don't know where Libya is in North Africa, and the capital is Tripoli, and it's where we have done the study. And we speak Arabic in this country. The population of Libya is around 7 million people, And out of this, there is around 2 million people who are the working population. This number was based on the recent survey that was done in 2022. So we do have some regulations and we do have some regulations and rules for occupational health and safety. However, the implementation of them is still not that effective. So, for example, here we have a small table that show you the sectorial distribution of this working population. Libya's economy relies mainly on the petrochemicals, and the percentage of people who work in manufacture or in production is very low, only 6%. And in human health and social work, there is around only 8% of these people working in this sector, which is also low. However, there is, on the positive side, in the recent years, a new research trend is being initiated. Most of the people are becoming more aware of the importance of doing studies and collecting data and having a database, and the importance of research in general. So this is a good thing that's happening now in my country. So what's the aim of our study is to investigate if there's an association between psychosocial risks and diet quality, and psychosocial risks and physical activity among healthcare workers. So the study population, we have targeted one hospital in Tripoli, which is the burns and plastic surgery hospital. This hospital is one of the biggest hospitals in Libya, and in Tripoli, it's the only hospital that focuses on the burns cases and the plastic surgery cases, mainly burns. So all these cases come to this hospital, and even from rural areas. So there is a high load of patients and cases in this hospital. So our aim in sample size was to reach at least 60% of the total population of the hospital, and we targeted the medical staff only, so like physicians, nurses, technicians, physiotherapists, etc. So only medical staff. We were able to cover 70% of the population, so we have interviewed 260 medical staff at this hospital. For evaluation of psychosocial risks exposure, we have used COPSOQ, the short version. We included around 15 domains, and we have also included 4 health outcomes that are included in COPSOQ. For diet quality evaluation, we have used the short version of Healthy Eating Index. And also, during the data collection, I was taking with me some food models to show the participants what does a portion mean. So they can have an idea when they answer the questions, or they can visualize what these foods mean. For evaluation of physical activity, we have used Golden Leisure Time Physical Activity Questionnaire. And we also have took some anthropometric measurements, such as weight and height, to calculate the BMI. And we have also measured the waist circumferences to measure the fat around the middle of the body. For statistical analysis, so this is only the primary results of the study. So we have used basic tests, such as descriptive statistics. We have used t-test, t-independent test, to calculate the means difference between psychosocial risks and the healthy eating scores. And for the association between physical activity and psychosocial risk, we have used chi-square. And for the health outcomes in COPSOQ, we have used the chi-square as well. So these are the main, these are the main findings of the study. As you can see here, around more than half of the population or the sample were females. And they were mostly healthy. The population were mostly healthy. 74% reported that they have no health issues. The smoking rate also was low in my sample. 17% only reported that they are currently smokers. However, this I think is also due to the fact that the majority of the sample were women. The prevalence of smoking among females in my country is significantly low. The mean age of the population was 35 years, sorry, and the years of work, the mean years of work at this hospital was 10 years. So these are the categories of the people we interviewed. So there's doctors, nurses, technicians, include X-ray technicians, laboratory technicians, and the others means that pharmacists, physiotherapists, etc. So the first finding that we have observed, and it's a very important thing, the prevalence of obesity in our sample. So let me remove this here. So as you can see, the percentage of obesity is very high in the sample. Around 40% of the total participants were obese. So they have a BMI above 30. And as you can see here from the graph here, women are usually have higher BMI results, which indicates that there's a gender difference. Also here, if you check the normal weight or the normal BMI, here men have higher percentage, but in general, the percentage of obesity is high. So it's like around 40%. This was also similar for waist circumferences risk. As you can see here, only 30% of total participants showed lower risk for heart disease and circulatory diseases. And if you combine these two, around 65% of the participants had risk or high risk for heart diseases. We also 4% we didn't include their measurement because some of the ladies were pregnant and measuring waist circumferences for them will be inaccurate. And for physical activity outcome also was important. As you can see here, the percentage of people being insufficiently active was very high, so that 65% of the sample were sedentary. And also, again, women had a higher percentage of sedentary physical activity. For being physically active, men tend to be more active than women here, like 33% of men were physically active compared to only 10%. But in general, physical activity was quite, physical inactivity was quite high here. So for our main aim, comparing the psychosocial risks and the healthy eating index score, using the t-test, we have found that the meaning of work domain in COPSOQ had a significant difference in means with healthy eating index score. So as you can see here, the total p-value was significant. When we did gender analysis, when we compared men and women, we have found that this significance mean was only for females, and males had a different significant p-values in predictability domain and trust in management domain. So there was a difference here. Again, for the health outcomes, we have used 4. 2 of them showed a significant difference between means. And again, we did the gender, we compared genders, and we found that this significant p-value was only in females, not males. For the association between psychosocial risks and physical activity, we have used chi-square here, and there was an association between 2 domains and physical activity. There are trust in management and commitment to workplace. Again, we have done gender analysis or we compared genders, and we found again that this relation or this association was only observed for females, not males. For the health outcomes of COPSOQ, we assessed the association using chi-square, and 3 of the COPSOQ domains had an association with depressive symptoms, work and family conflict, emotional demands, and meaning of work. As you can see here, the p-values. And then for stress association with the COPSOQ domains, 4 of them had an association. Work and family conflict again, justice, possibility for development, and supervisor support. And again, these are the p-values. For the third symptom or health outcome, which is burnout, 5 COPSOQ domains had an association, work and family conflict, again, work pace, emotional demands, quantitative demands, and influence. Also, the p-values were significant. And then the last one is sleeping troubles. 5 COPSOQ domains had an association, work and family conflict, justice, recognition, predictability, and commitment to workplace. So just to summarize the findings quickly, there was a significant mean difference between when we analyzed for healthy eating index scores. And also there was an association between some psychosocial risks and physical activity. And there was a notable gender difference in many of the tests. And of course, there was a high percentage of obesity and physical inactivity. Okay. So what are the implications of our study? There are twofold. Implications are in twofold in this study. So there's a clear need for a workplace or targeted workplace intervention that to mitigate the psychosocial risks and also to include the healthier lifestyle behaviors in the workplace. And also, second thing is we need to create a culturally adapted health promotion programs that take into the account the unique physical activity and dietary patterns of the Libyan population. So this study here mentioned highlights the effectiveness of such interventions. And for future research directions, we need to investigate the longitudinal impacts of psychosocial risks on health behaviors so we can establish causality. And also, we need to expand this research to include other or multiple healthcare facilities so we can, and in different regions as well, so we can enhance the generalizability of this study. Our study also had few limitations. The first one is the sample diversity, of course, because this study took place in a single hospital only, and it included only medical staff, so we didn't include the administrative staff, for example. So this was a limitation. Also, the cross-sectional design can only identify association, and it cannot establish causality. The third limitation is the self-reported questionnaires that's used for the physical activity and the dietary habits as well, because this can like introduce bias and inaccuracies because the participant might misunderstand or misreport their answers. And we used COPSOQ short version. Also, we couldn't use the long version because of the time limitation. As I said previously, this hospital is quite busy. So the doctors and the staff were rather overoccupied. So to conclude, we have found an association and significant difference in means for healthy eating index and for physical activity. And we also found gender differences. So we need, or this can suggest that we need interventions that take this variation into account. They might be very effective. And moving forward, we hope that our study can inspire policymakers and healthcare administrators to include psychosocial risks into their health promotion strategies by integrating multi-level interventions that can improve the healthcare workers' well-being as well as their productivity, which also improve the patient care at the end. And we encourage the ongoing research on exploring the association between psychosocial risks and health behaviors. We might be able to develop sustainable health practices that can be implemented in Libya and also in other similar healthcare settings. So I want to share a fun fact about Libya. Libya emerged as Africa's happiest country in the annual World of Happiness report for 2024. And thank you so much for your time, and thank you for this opportunity. And I'm happy that I met all of you. Thank you.
Thank you for this very interesting presentation. And I would ask the participants to, if they have questions.
I have a quick question, if that's okay.
No?
Great.
Yes, sure.
Thank you for your presentation. I really enjoyed you kind of sharing your findings, and I could tell you're really passionate about this subject, so it was really great to listen to. I wondered if you could share perhaps how long it took your healthcare workers on average to complete the short version of the questionnaire.
So my questionnaire was a bit long because it contained the Healthy Eating Index questionnaire, and it also included COPSOQ, and it included the Golden Leisure Time Physical Activity questionnaire. So there were three
that's great.
scales in my study, and it took around 15 to 20 minutes to finish. And for some people, because they were very interested in this subject, they were asking so many questions. So sometimes we reach even 30 minutes because of they're asking so many questions.
Oh,
So
okay.
yeah, so three scales, they took around 15 to 20 minutes. And
Okay.
it was an electronic questionnaire, by the way. We have used Kobo Toolbox, and I had iPads and laptops with me, and I was interviewing them kind of one-to-one.
Okay, that's good to know. And then just a quick follow-up question to that. I wondered if you could speak to kind of any resistance that you may have met from hospital or healthcare management with kind of their time and doing that survey, kind of donating that 15 to 20 minutes. Was there resistance? And
Yeah.
if there was, maybe how did you overcome that resistance?
So some of the managers were like, you're taking time of our employees and we're kind of busy. But like in most of the time, I was trying my best to come in their free time only. So when I find them busy, I go to a different department. So the hospital is so big, I go to the emergency department. I find them busy, I go to another department. I take someone from here and then go to the pharmacy, for example, in the hospital, and take someone from there. So I try to find the free people, so I don't take so much of their time, and I avoid the problems. Because yes, I found some resistance from some of the managers, but because I took the acceptance from the manager of the hospital and I had a paper saying that, so I didn't have that much problem, as long as I respect their time and I respect that they're busy at that time.
Okay, thank you. Thank you so much for sharing.
You're welcome.
Thank you for your presentation. Do you have any explanation why you, regarding physical activity, found more COPSOQ factors to be associated with physical activity among women as among men?
Yeah, so for physical activity, I believe that the infrastructure of my country itself affects physical activity. For example, our country roads and like the infrastructure in general does not encourage physical activity that much. It's not suitable. So for people to be physically active, they need either to go to the gym or they need to drive their car to somewhere to even have a walk. So not all the streets are suitable. So you can't just walk close to your home. So that's, I think, the reason why physical activity was low. and it was associated with many risks. Most of them do not have time. When I even talk with them and ask about physical activity, they start laughing sometimes and say, we only walk at the hospital if you would count that as a physical activity. Most of them say the same word.
Okay, thank you. Thank you
No.
for this very interesting presentation. So now we have listened to how to adapt COPSOQ to fishermen's situation in New Zealand, and I'm sure that if you would use COPSOQ among fishermen in other countries, you would maybe encounter the same problems. And then we have seen a validation of the Russian version of COPSOQ, and we see forward to see their results in the time to come. And that would also apply to the Belgian situation, where they try to see if one can distinguish between organizations with problems and what COPSOQ factors do distinguish between organizations regarding need for recovery. And in the end, we have seen a very new and interesting approach from Libya, trying to see if psychosocial working conditions are related to eating habits and physical activity. And there are some interesting gender patterns were shown. We could discuss that for a much longer time, but time is running out. And thank you to all presenters, to Marwa, to Philippe, to Anna, and to Fatima.
Yes, and Herman, if we can also recognize that Tate Christensen is online, and he, for those who don't know, is the quote-unquote grandfather of COPSOQ, and we're very honored to have him join us today. Thanks.
Thank you, Herman, and thanks to all the speakers. It was a really good session and so many different perspectives on the use of the tool, which keeps getting adapted and, I guess, broadened in its ability to help us understand workplaces and particularly to drive prevention of harms, physical and social and psychological harms in workplaces. So it's really very interesting, and I really appreciate, Herman, you chairing and the continued involvement of the COPSOQ network in our annual event here, so that we can have one of our 4 or 5 sessions where we're drilling down on the use of this important tool that's being used so widely around the world. So I did put in the chat, of course, the links to our next 3 sessions, and you're all welcome to attend from they're more Ontario focused, but there's information about some research studies next week, and John is presenting in 2 weeks on the 22nd about the importance of validation in survey tools, and then some new tools, actually, including a job demands analysis tool that OCOW has produced, which includes cognitive and emotional demands being considered, not just physical demands, in the job demands analysis. So we'll be sharing that on the 29th. So I don't know if each of the speakers, if anybody wants to have kind of a last word, we normally do that. Fatima isn't here. Anna, did you have anything you wanted to?
Tay has something to say.
Oh, great. That would be great. Go ahead. Can you unmute?
I think Target just wanted to say goodbye.
Oh, okay. You didn't want the stage. That's great. So, Anna, did you have anything you wanted to share?
Yes. And here.
Yeah, we just wondered if you had anything any final comments. That's all about the use of the COPSOQ or anything else. before you say goodbye?
Thank you very much. Thank you.
You're very welcome. And thanks again for presenting today. How about, and I'm trying to remember who was next. I think Philippe. Do you have anything else you want? Any other comments?
No, I have no other comments. I'm very thankful. I'm sorry I cannot put on my camera, so you can't see my face. But it's the hair is growing much more whiter. That's all. And for the rest, thank you very much for this opportunity to present this on your fine conference. Thank you very much, and I hope you have a very nice vacation ahead.
Thanks very much to you too. And we are sorry we couldn't see you, but as you saw, a number of people asked for the slides, so hopefully we can post all the slides on the event page in the next few days too. And Marwa, how about you or Uchel? Did you want to add anything?
Thank you so much. I have no comments, but I'm very happy that I was here with you guys, and this is a great opportunity for me. Thank you.
Great, thanks.
Thank you for your support.
You're welcome. How about Herman or John? Anybody, anything last for this year, or we'll reconvene in a year, I guess, although you'll have other network meetings before that, I guess. Oh, and the in-person meeting, I guess, is in
Malmo, Sweden.
Malmo next year, I guess. The information's on the website.
Yeah, the COPSOQ International Networks website.
We are next in a year. We will get very close to Copenhagen. You just have to, if you are a good swimmer, or you can also take the train over the Strait of Øresund, then you are in Copenhagen. So we are very close to Copenhagen in a year, and we meet in Malmo, and there we can maybe discuss some of the issues further that were taken up today, both regarding physical activity, regarding fishermen, seafarers, regarding cut points, and regarding new language versions also.
Great.
I put the link in the chat.
Good. Thanks, John. Okay, I think we'll say goodbye now so people can go to bed or go have dinner or go have lunch, depending on where they are in the world. So thanks again, and hopefully we'll see some of you next year. And safe travels. Take care.
Bye.
Bye-bye.
Bye.
And of course,
Bye.
yeah.
Bye.
Bye-bye.